Okay, we're going to go ahead and get started. So welcome everyone to the pre-application webinar for the Electronic Case Reporting for Tribal Nations project. My name is Sarah Price, and I'll be giving you a little bit of background information about that project today and answering any questions you might have as you consider applying for this. Just before we start, just some webinar protocols. I do ask that you keep your phones and your microphones on mute when you're not speaking. There will be plenty of chances to ask questions. You can unmute at that time. This will be an open conversation, so if you have questions on specific slides, that's fine. But just to minimize background noise, I do ask that you stay muted when you're not speaking. You can also use the chat box at any time to ask questions. Please note that this meeting is being recorded. If you do not consent to being recorded, I ask that you drop off at this time. And thank you everyone for your understanding and cooperation. I'm going to give everyone just a moment for anyone who does want to drop off. Okay. So this funding opportunity is being offered by the National Indian Health Board. For those of you that may be unfamiliar, I wanted to share our mission statement. So we were established by the tribes to advocate as the united voice of federally recognized American Indian and Alaska Native tribes. We seek to reinforce tribal sovereignty, strengthen tribal public health systems, secure resources, and build capacity to achieve the highest level of health and well-being for our people. And this project is specifically being offered under the Public Health Policy and Programs. So this is the Policy and Programs Department works specifically on public health to build thriving tribal communities now and for the next 7 generations. So today we're going to be walking through the electronic case reporting process and a little bit about what that means and what that looks like. We're going to walk through this specific funding announcement, and then we'll have plenty of time to give you all a chance to ask questions about this funding opportunity. Before we get started, I do want to allow our partners to introduce themselves and introduce myself. So my name is Sarah Price. I'm a public health program manager with the National Indian Health Board. I've been with the National Indian Health Board about 5.5 years, and I work on a lot of our infrastructure projects. So I've been working on this project for about a year now, since we've really been getting it underway, and I'm excited to work with you all. And I'm going to turn it over to our partners at CDC. Sarah Sabonia, do you want to introduce yourself?
Sure. I'm Sarah Sabanya. I work on the electronic case reporting team at CDC. I'm our health equity coordinator, and I'm glad you're all here, and I'll turn it over to Melinda.
Hi, good afternoon, good morning. My name is Melinda Thomas. I am the team lead for the Public Health Agency support team within eCR. So I really, work with a team to, assist public health agencies where needed to implement eCR just broadly. So I'll pass it back over to Sarah.
Thank you. And this project is a joint effort between the National Indian Health Board and the Centers for Disease Control and Prevention. So CDC partners will be part of your technical assistance team, and we'll be here to answer some questions as well if you have any. Okay. So just to give you some background on what electronic case reporting is, electronic case reporting is the automated real-time exchange of case report information between electronic health records and public health agencies. This project specifically focuses on tribal public health agencies within this process and their access to reportable public health data. There's a lot of benefits of this process for public health agencies that receive eCRs. So this can provide more timely and complete data to support outbreak management and monitor disease trends. It allows public health agencies to effectively monitor the spread of reportable diseases like COVID-19 if there's outbreaks and public health emergencies. It reduces response time since everything is automated, and it improves communication and collaboration between healthcare and public health. This is really a change from traditional case reporting, which some of you may be familiar with, which has no real singular place where you can access this information and varies pretty widely across jurisdictions. Because the electronic case reporting automates the process, it makes the data suitable for machine processing and makes the data move across different organizations a lot faster. So this slide is meant to give you some background on what electronic case reporting looks like. So a patient will be diagnosed with a reportable condition. This could include something like COVID-19 or other infectious diseases that are considered reportable. the healthcare provider on their end will enter information into their electronic health record system. Because that system is connected to this electronic case reporting system, that data will actually trigger a case report that's validated and will be sent to the appropriate public health agency if it meets your reportable criteria. So if that is the tribal public health agency, any tribal citizen that is within your jurisdiction will automatically be triggered, so you'll receive that case report. The public health agency will receive that case report in real time, and you'll be able to respond about the reportability back to the provider. That'll happen again automatically. And then this as state or local health departments will reach out to the patient for contact tracing services or public health actions. Of course, tribes are also public health authorities, so also can choose to do the contact tracing pieces. So this would be a benefit of having those cases, is you could engage in that contact tracing. I should note that not all electronic health record systems are currently reporting to the eCR system, but many of them are currently getting set up. RPMS is not one of them, so that's something, just if you have any questions about if this will be something that's helpful for your public health agency at this time, just let us know and we're happy to talk this through with you. And here's a little more detailed breakdown about how this looks. Sarah, I'm actually going to turn it over to you if you want to talk a little bit about this slide.
Sure. Happy to. Yeah, this is the more complicated one. So starting on the left, you've got the provider's electronic health record systems. There's two ways that these electronic health record systems can trigger and generate and send the reports. One is with eCR Now Fire app that we developed in 2020, and the other is by building that capability into their product. For you as the tribal public health agency, it doesn't make any difference. You're going to get the same data either way. So the reports are going to be triggered on the provider side. They pass through some sort of a policy framework. Could be eHealth Exchange, an HIE. It could be, various things, or it could go directly to this APHL AIMS platform in the middle. So on that AIMS platform is a decision support engine called RCkms. So you as the public health agency will have already logged in to that RCkms platform and entered your what we call your authoring, so your rules for reportable condition. So you could say, in our jurisdiction, Rocky Mountain spotted fever is reportable, and we want to count a case if it gives a positive result on this lab test, or if it has one of these symptoms and also a history of exposure. And you decide that what your criteria is for a reportable condition. There are 173 reportable conditions currently available, and we added a new bunch every 6 months or so. So once the information that's been triggered in the electronic health record reaches this APHL AIMS platform in the middle, this decision support engine compares the information in that electronic initial case report with the criteria entered by the public health agency. If there's a match, then the report is sent on to that public health agency. If there's no match to any public health agency, it's deleted, disappears. No one ever has access to it. If it matches the criteria for two public health agencies, so for example, someone who lives on tribal lands received care in a hospital that's not on tribal lands, well, then the report might be sent to two public health agencies. If your public health agency said, we want reports for anyone who lives on tribal lands, and maybe the state says, well, we need reports for anyone who receives care, in our jurisdiction, then the report can get sent to both. And then the last piece is that reportability response. So the provider gets a reportability response, which is RR in this diagram, that just tells the provider, you generated a report for Rocky Mountain spotted fever for, this is the patient's name, and it was found reportable for Rocky Mountain spotted fever to the jurisdiction of Oklahoma or wherever. And the public health agencies also get those reports. I think that's it. Over.
Thank you. And RCkms is really that first step of what you'll be doing on this project with us. So that's where, as Sarah said, that you'll be putting in reporting information, what you consider reportable. You'll also have a knowledge repository where there's a database that contains default settings for jurisdictions. And that's where that decision support service is really housed, so that you'll be able to update that regularly, what type of reports you want to receive. I do want to stop now because I know we're going to transition a little more into the actual project itself. So I want to see if anyone has any questions at this point. And if you do have a question, feel free to unmute or to put it in the chat. I do see 2 questions in the chat. One, if there will be a recording available afterwards. Yes, we will be sending a recording and a follow-up announcement that will go out through our listserv. So you'll see that come out probably tomorrow morning. And the slides will also be shared within that announcement. Okay, I'm not seeing or hearing any other questions, so I'm going to move on. Okay, and just so you all know where this project aligns as far as the larger work that we're doing, this project is really part of a larger effort to increase tribal access to electronic health data for reportable conditions. We know that tribes have major barriers, even though they are public health authorities, in receiving timely and accurate case reports for tribal members. So this is meant to be an additional tool that assists tribes in accessing your health data, hopefully without having to go through a jurisdiction such as a state or a local, although we of course always encourage you to try and partner with your state and local when possible. So you also know what else will come out of this. You're really a pilot. This project is pretty new for everybody, not just tribes, but particularly for tribes. So we're all really learning, and one of the things we're going to be creating is a roadmap for tribes. So if you join us in this project, you'll be really informing this roadmap. We have 2 pilot sites that are already working towards connecting to the eCR platform, who are helping inform this process as well. So switching over to the project itself, as I noted, this is a project that's offered by the National Indian Health Board, but we're supported by the Centers for Disease Control and Prevention as part of a larger effort to improve electronic health access data. This project is specifically going to fund up to 2 tribes for up to $350,000 each. The project period is expected to run from approximately March 1st to July 31st. And completed applications will be due February 8th. I do want to recognize that this is a pretty quick turnaround for this project. So I just want to reiterate that we're really committed to working with our partners to complete this project in a good way. We do have plans to support 90 days for concluding outstanding activities, which will bring you to a time in October. The CDC and us are working pretty closely to make sure you all have enough time to conclude this project in a good way. So this funding is for any eligible applicant, which includes tribes, tribal organizations, and tribal consortiums that have public health authority. Tribes are inherent public health authorities, and then also tribal epidemiology centers, which have been granted public health authority due to the role in supporting tribal nations. So if you are from a tribe, a tribal organization, a consortium, or an epicenter, you have public health authority, you are welcome to apply. We do ask that you have some demonstrated commitment to or interest in either surveillance, data sovereignty, or electronic case reporting, just to show that you are ready to sign up. However, if you do not have public health authority already given to the public health department, we do need some support from your tribal council just to let us know that they have approved you for this. But we can work with you if you're working on having some sort of formal legislation from your tribal council to give a tribal public health department public health authority. We're going to fund 4 different areas of this project. This is kind of the progression that you'll go across during the project period. So the first step will be to prepare, where you'll assess your current data management and data storage processes. You'll identify your needs and your gaps to receive and process electronic case reporting data. So that piece is really internal. Then you're going to connect to the system and the processes needed to receive this data. This really involves partnership with your health informatics team, so that you can get connected to the Public Health Lab's AIMS platform. The next step once you're connected will be to author. So this is where you'll decide the criteria for what is a reportable disease for your community, and you'll enter that information into RCkms. And then finally, you'll engage in coordination and partnership. This will be ongoing throughout the project, but you'll establish the necessary processes to ensure that timely and successful project implementation, both internally and if you are able to partner with other external partners such as the state and the locals. Okay, I am going to briefly walk through the RFP just so you all know what is necessary to apply. So this is what the RFP looks like when you download it. The first page is really just information that we shared with you about this project and eligibility information, project requirements, which are mostly that you'll complete the activities, that you'll have a point of contact, just basic projects, maintenance. And then for a complete application package, you're going to complete sections A through D and have several attachments. So this will be including your tribe and contact information, your application narrative. You're going to have information on the award budget and supporting documents, and then your proposed scope of work, which has partially been pre-filled for you based on the work plan. You'll also have to attach a budget narrative and line item budget and a letter of support from your tribal official. If you do have indirect costs, you should also be attaching that. And we will need your financial audit prior to signing a contract with you, but that is not necessary to be submitted with your application. There's other supporting documentation you can provide. This can include if you're working with a contractor, you can provide that, or if you have support from other public health agencies that you're partnering with, you can include that, but that is only if you believe that would strengthen your application. It's not necessary for you to be accepted. You will submit all this information to my email, sprice@nihb.org by February 8th with the subject line eCR for Tribes application. And afterwards, a team of public health experts will be reviewing this application and determining if you will be selected. We will let you know by March 1st if you've been selected for this. And then if you go through this application, you'll see that it's just click to enter information. This section is about just entering background information about your tribe, your point of contacts, project coordinator, and then having an electronic health official, signature of a health official. The narrative is really where you're going to demonstrate that you are intending to support this project, that you have the capacity to support this project, and to describe how this project will help your community and improve your public health processes. So you'll give a description of your needs, your improvements, and how this will improve your capacity, and who will benefit from this project. For section C, this is just information about the budget that you will be submitting. You do not need to fill out anything in this award budget section. You will be attaching that award budget as a separate attachment. You should just read through this section to make sure you have everything you need within it. And then the only thing you do need to fill out in this section is what supporting documentation you will be including. You can just check these boxes, and then those will all be included as attachments. So that's all you need to do with this section. And then finally, section D is your work plan. The work plan is pre-filled. So all the activities that are pre-filled in the work plan are required to successfully connect with the AIMS platform and the eCR system. That being said, you can absolutely add activities, and you likely will need to customize this project. So please feel free to add activities as necessary and assign funding to those activities as necessary for your own successful implementation. You're the only ones that know what your internal capacity is and what you need to get this set up. So feel free to edit this and let me know if you have any questions. You can reach me by email or by phone. And then at the end, you'll have a checkbox just to make sure you've submitted all application materials. Okay. And again, so what you need to complete it is those 4 sections, the budget narrative and the line item, the signed letter of support. And then these are all optional documents, the financial audit, the indirect cost agreement, and other supporting documentation. Although again, we will need a financial audit before you submit your final contract with NIHB. So as a reminder, you need to submit those by February 8th at 11:59 p.m. And that is really an overview of the application. So I'm going to open it up to everyone for questions. And to ask a question, you can either unmute yourselves or you can put it in the chat box and I'll read it aloud.
Hi, Sarah. This is Eric Coles from Tule River. I apologize. I came in late, so I may have missed this, but can you talk through the timeline and if exactly if like the grant period exactly ends in July or any flexibility with the timeline? Thanks.
Yes. So as of right now, we're expecting to be able to extend everyone by about 90 days to wrap up activities if they're not completed by July 31st. That being said, we're working with CDC to see if we can extend the timeline farther. I can't comment on what that might look like or if that will happen, but we are committed to trying to work with you to the best of our abilities to really give you enough time to complete this project in a good way. And we can share more information as that becomes available about what that final timeline will look like. But as of right now, we are expecting to be able to extend those 90 days past July 31st. Okay, and I have a question for CDC. Will the CDC assist with connecting the information exchange?
I can take that. Yes, we'll assist and we'll also connect you with assistance from the CSTE team, which is they're the ones who own the RCkms knowledge management system that we saw, and also the Association for Public Health Laboratories, APHL, are the ones that kind of own that AIMS platform. So you'll have access to expertise from all three organizations to help with this. You will need, IT people on your side. You'll need, someone with the technical expertise to set up that SFTP or S3 connection, or, a contractor to your organization that can do that. But we have people who will kind of walk you through where to connect to and how it all works.
Hi, my name is Crystal Stram. Can you hear me okay? Yes, okay. I'm actually not from a tribal organization, but I'm from MIHIN, the Michigan Health Information Exchange Network. And we are actually working diligently to onboard tribes to our services. And we actually have eCR as built into our health information exchange. And this may not be the right venue, but I was just wondering for the people on this call, if you had worked with any other health information exchanges and tribes in working out those data feeds and flows for this type of thing.
There are other tribes in the nation that are working with intermediary organizations, companies that assist with health records, HIT, that forward on the electronic case reporting to the tribal public health authority. So there are tribes currently in a similar, operating under a similar scenario, Crystal. And I'm not aware, I only know of one example. So it's not very many as tribes are ramping up the electronic case reporting, onboarding and implementation. But that it can you say the name of your organization one more time, please?
It's called MIHIN. It's the Michigan Health Information Network. And I was just thinking, I had seen this grant request come across, and we have eCR built, our data feed goes directly to MDHHS, to the state of Michigan. So our organizations contribute data, and then we send it to MDHHS for eCR. So we have a hookup through AIMS. So I'm just thinking, if I'm working on onboarding tribes in Michigan, it might be cool to think about figuring out if they onboarded to MIHIN, if we could somehow figure out a data flow directly to a tribal health authority. But again, I know this isn't probably the appropriate venue for this call, but just wanted to bring that to someone's attention here, and would love to chat more later on if we wanted to.
Yeah, we'll reach out after this meeting and try to set up a time to have a discussion, Crystal, around that. I know that there are I know that some tribe, that might work best for some tribes, but others may wish to directly have a feed into Ames and get that information themselves. So we might be able to talk offline and see how we can work together on that.
So, sounds good. Yeah, because we're working diligently in Michigan. We already have 8 out of 12 of the tribes hooked up to us. So
wow.
Yeah, so we could talk offline.
Great.
And Tyler, since you're on the call, we did get a question about the timeline. I let everyone know we have that 90-day period built in. Do you have anything else that you could add from the grant's perspective about that, or the timeline for new tribes onboarding?
Not at this time, other than we understand that the timeline is can be seen as maybe a bit aggressive or quick. So we want to make sure that you all understand that we would work with you in any possible way to make sure that the work was getting completed in a really good way, and that we have 90 days after the end of a grant period to close out a contract. So we would offer any sort of assistance that we can at that time to help make sure the work was getting completed. And while I will just say we cannot count on, and we won't plan for a no-cost extension to get the work done, there is always a potential for a no-cost extension at the end of a 5-year agreement. And so there could potentially end up being additional time after the end of this grant in July to finish the work as well. So we don't want it to be a hurried process. We want to make sure that good systems, good infrastructure, and good data flows are in place to make sure that the tribe's getting the necessary information. And NIHB will work with also awardees to make sure that that happens before the end of the project period.
This is Eric again. I have kind of a comment and a question, a comment for the CDC folks on the call too. So I work for a tribe in California, and one of my hesitations for this grant is concerns about kind of the working with the state and their access. Historically, they have not provided access to state level data to tribes, to my knowledge. So I know this is kind of skirts the state system of a little bit, but that is something like concerned about a bit in my mind. So some sort of written communication or clarity for us to share with the state would be really, really helpful. And then second, I just want to make sure I'm understanding it right and framing this opportunity correctly to the tribe I work for. Ames is only kind of one potential area where kind of tests are taken, right? I guess I'm wondering, through setting up these connections, would we also have access to people who test through private labs or through the local hospitals as well? Or is it strictly only like the county public health lab? Does that make sense?
Yeah, I can take that if that's okay. Yeah. So I think there's some confusion about the Ames platform because it's run by the Association of Public Health Laboratories, but they just provide that platform. It's just a place that holds it. We actually have over 22,100 different healthcare facilities that are connected for eCR right now, and they are hospitals, they are urgent cares, they are clinics, they're physicians' offices, they're rural health clinics. We have one tribe that has its entire tribal healthcare infrastructure reporting with eCR. We have 3 other tribes and tribal consortiums that are in the process of getting their healthcare facilities connected. So it's not just labs. And in fact, labs don't actually report with eCR. Labs do something else called electronic lab reporting. So this would just be for the providers. And you as the public health agency or public health authority would receive any reports for people living in your jurisdiction for anyone who receives care at any of those 22,100 facilities. The data in the electronic health record would show that the person lived in your jurisdiction based on the zip code, and based on that, the report would be routed to the tribe.
So Eric, for example, if you have a tribal citizen that goes and seeks care from a private clinic off reservation, you guys would still receive that electronic case report if that private clinic was reporting into AIMS, right? And that tribal citizen had an address that originated from the reservation. Does that make sense?
Yes, yeah, and I'd want to talk further because I don't think it's going to be as clear as zip code, because I think we share a zip code with the nearby town. But that's great to hear. One kind of minor question. So I work for Indian Health Clinic that has 638 funding through IHS.
Mhm.
That we're able to serve everyone within the county who is from a federally recognized tribe. People who live off the reservation but who qualify for care at our health center, do they count for for us as a public health authority as well?
I mean, I take that, Tyler. I can. I mean, I think so. Ideally, we would want to be able to route based on tribal membership and tribal affiliation, and that is a new data element that's just been incorporated into our eCR implementation guide last July. It's not yet being used yet because the electronic health record software vendors don't yet have a place to put it. And then if someone went to see a clinician, they would have to share that information with the clinician, and then we would have to get the AIMS platform to use that for routing. So in the future, I think that's definitely going to happen. For now, the only way we have for routing is by zip code. So you can get EICRs for people who live in your jurisdiction or for people who receive care in your jurisdiction. And because your zip code, because your jurisdiction is not the entire zip code, there are issues, and I am aware of the issue with California about that you would potentially get reports that really aren't part of your jurisdiction just because of that shared zip code, which is also something that we're hoping could be worked out, but really isn't yet. I mean, what's happened up till now is that, if a state or a tribe or a state and a local health department share a zip code, they just kind of agree, we're going to investigate ours, you investigate yours, and then we'll just securely delete the others.
Yeah.
Yeah.
So while this is still very new, right? So we are, things are in the works to really try to make sure that clinicians capture tribal citizenry. And that is part of the health records. So the tribe is able to get the, their citizens' data. That's still very much in the works because this is so new.
Yeah,
But
that's
thank you.
fantastic. Yeah, I'm really excited about this regardless. I know there's some little issues, so I'm still really, really positive about it. I just wanted to see, because again, we're having some legal issues, but no, this is really, really great. I'm really excited about it. Thanks.
And I just want to, I think Tyler mentioned this kind of as an aside, but this is a really new program. This was a tiny little pilot with 170 facilities in January 2020. So we've scaled up from that 3 years later to, over 20,000. So I know I talked with Tyler a year ago, and I think he just kind of assumed this had been going on for years. And it's like, no, you are actually getting in on the ground floor here. But that means, there are still things that need to be worked out. So we're working them out as quickly as we can, but not quickly enough.
And the important part is we're working it out with the tribes, right? So often tribes come in, are brought in after things are already set up and systems are already developed. This is an opportunity where tribes are coming in at the ground floor and able to help build the system that will help work for them and their needs too. That's why this is so very exciting, and really a good sign that as far as health data is and electronic case reports are concerned, you know, the federal government is really engaging with tribes from the beginning to make sure that this is done right. And Crystal, yes, I see that. I believe that based upon IHS area, there might be different, and even from tribe to tribe, there might be different criteria on what folks can receive care at tribal facilities, right? Some
Right.
allow
That's what I was thinking, because I'm a tribal descendant. I go to a tribal clinic that's near me, but I don't belong to that tribe. My mom belongs to, so that, but I realize HL7 and all those things they're still just trying to get hold of the actual tribal citizen thing. So yeah, I'm with you.
So, you know, not saying that won't ever be a part of the equation, but right now that's really not factored in. And as the system kind of grows and matures, there might be an opportunity to really kind of have maybe some tribal specific or region specific aspects that are considered. You know, I have lots of friends. I'm from Oklahoma. I have lots of friends who were able to go to tribal healthcare facilities because their parent had married a tribal citizen, and so that tribe allowed children under the age of 18 and to be able to receive care there. So there are a lot of kind of nuances that, as we start to get the bones of this in place and we have tribal citizen being collected, you know, which tribe are you a citizen from being collected, we can then start to like build off of that, right? So.
And the goal is for us to have this project so that, you know, each tribe determines their own service area. And then the goal will be that the tribe gets all the reports for whoever they consider within their jurisdiction. It's easier right now since it's zip code based. If you live in that jurisdiction, that's really the big barrier. But that's going to be, I think, also something that can be set up a bit on the tribe side in some tribes where there's already some ways to do this where people might be living in that jurisdiction. So that's something, if you know, if tribes are applying for, we'll work with them to figure out the best way to address that within the current limitations of the system being so zip code based. Right. Any other questions? You can unmute, you can put it in the chat. Okay. Well, thank you to everyone who joined us today. I will be reachable after this call for any additional questions. If you have anything specific to your community or your tribe, please feel free to reach out to me either by email or phone, and I'm happy to work through those with you. Oh, I do see one more question. Is there a technical documentation for connecting to the exchange? For that, I am going to refer to CDC again.
Yes, and if you give me a second, I can find the APHL-AIMS website where they go through all of that. And then, you know, again, they'll also kind of walk you through it. But here, let me put that in the chat. And you can also reach out. Our email address is ecr@cdc.gov. So if you have more technical questions, you know, about ECR and not specific to the project, we'd be happy to answer those as well. Thanks, Tyler. It's good to see you. I like your mustache.
Yeah, thank you. New addition today.
Oh.
Well, thank you everyone for joining. I'm going to stop the recording, but if anyone does have any questions that they want to ask, you feel free to stick around. I'll stay on the call for a few minutes. Thank you. I hope to see a lot of you apply or to work with many of you in the future on this project as we grow it. Thank you, everyone.
Thank you so much.